Good morning, everyone. My name is Dr. Sara Bayes, and I'm the Associate Professor of Midwifery and the Director of Midwifery Studies here at Edith Cowan University in Perth, Western Australia. Thank you so much for joining me today to consider the impact of novel coronavirus 2019 or COVID-19 on the health and well-being of pregnant women, their babies and the wider family. Before I go any further, I just want to respectfully acknowledge the past and present traditional custodians of the land that we're meeting on today, the Noongar elders and people. I also just want to remind you to click the Q&A button on the right side of the screen to ask me a question. And I will try and answer all the questions, but time might not permit this, but I will do my best. And I just also want to let you know that a link will be made available to this recording after the event, and we'll also ask you to provide feedback via a survey. So I will also just mention that we happen to be meeting to discuss this topic on International Day of the Midwife. So a big shout out to all the midwives here for all the life-changing work that you do. Okay, well, for the next 15 minutes or so, I'm going to focus on three aspects of having a baby that have been affected by the virus. First, we'll take a look at the latest research on what we know about how the virus affects the health and well-being of the pregnant woman and fetus. I'll then outline how maternity care is being delivered to minimise the risk of infection transmission to all involved, and how that is impacting women's care choices and experiences. And I'll then finish off with how support for new parents is being provided when connecting in person isn't possible. And before I sign off, hopefully, as I said before, there'll be a little bit of time to answer any questions you may have. So what do we know about the impact of COVID-19 on pregnancy? Well, despite the fact that 70 or so research papers have been published in academic journals about COVID-19 and pregnancy in the last month, we still actually have very little data to go on. And that is because of the relatively small number of pregnant women confirmed and recorded as having the disease. What we do know is changing almost daily, and I have checked the research this morning and nothing new overnight, so I'm fairly confident that what I'm telling you is latest best evidence. But from what we do know, let's start with some cautious optimism, a good place to start. The latest published information, which is a summary of 33 studies published before 19th of April this year, that report the incidence and impact on the virus of 385 childbearing women from 12 countries, predominantly China, Italy and the Netherlands, suggests that pregnant women are at no greater risk than the general population of contracting the virus, and nor does it seem to be more severe in pregnant women than in others. So that means the same proportion of pregnant women as in the general adult population have been reported to contract COVID-19, and the same proportion develop either mild, severe or critical illness from it. And in terms of mild illness, around 96% of the population will experience that. Severe illness, which means that up to 50% of lung capacity is affected, is about 3%, and those who will go on to experience critical illness is less than 1%. And there have been several discussion papers in which it's been theorised that pregnant women are more susceptible to infection because of the normal immune system changes that occur when a baby is on board, but that hasn't yet been reported to date to have translated to actual cases. And that may be because pregnant women are in fact not more susceptible to viral infection, or it might be that they are tending to apply more stringent infection control measures than others. Who knows? Suffice to say, we need to keep an open mind, but at this point the news seems fairly positive. What the latest research also tells us is that for women who do contract COVID-19 in pregnancy and have mild or severe symptoms, so the 96 and 3% respectively of the population I spoke about before, it is probably not going to have any impact on their birth outcome or their new baby's well-being. And again, I do want to remind you that this is based on a very small number of cases, so we must consider that this advice may change, but for now that is what we know. The picture does, however, from the very few cases reported so far, look much bleaker for women who have a critical response to the infection and for their babies. So of the 3 women internationally who have been reported to have fallen into this critical group, which means they've had multi-organ failure as a result of the virus, 2 didn't survive and nor did their babies. And of course, every statistic like that represents an unimaginable loss to a family. And my heart goes out to them. But I do want you to remember that proportionate to the number of COVID-19 cases overall and the number of women who give birth globally every year, these losses do represent a minute likelihood of that happening to other women as a result of this disease. So that covers women and babies who've made it to full term, or what we call over 37 weeks of pregnancy. But what about earlier in pregnancy? Let's have a look now at how the virus seems to affect mums and babies who aren't as far along. And again, it is with the caveat that we need to exercise care because of the very small amount of cases that we have to go on so far. Well, the latest reports on outcomes for women across the world who are what we call preterm, which is less than 37 weeks pregnant, was also published on the 22nd of April, and it tells us that in women with confirmed COVID-19, there have been no reported cases of miscarriage in the first trimester, so the first 3 months. There has been no impact on their baby's growth in the womb. But there does, from a very small sample of 31 women, seem to be an increased likelihood of their waters breaking early, of them going into preterm labour, and of actually having the baby early. And we don't know for certain that the virus has been the cause of that, but what we do know is that preterm labour, preterm rupture of membranes and preterm delivery can be an effect of a mother not being well oxygenated, or of her having a fever, both of which can occur in a viral respiratory infection such as the ones we're seeing with COVID-19. So there is a fair chance that the 2 are linked. And finally, in all women with COVID-19 illness, regardless of the severity or how many weeks along she is, the latest information tells us that the risk of vertical transmission, which means transmission from mother to baby before or during birth, from COVID-19 positive mothers to fetuses during labour, is thought to be extremely low, if any. So very low numbers of newborns have tested positive for the virus after birth. And in those, the virus has not been detected in their umbilical cord blood or in the fluid that surrounded them prior to birth. So another form of infection transmission is assumed for those babies. There are reports of the virus being detected in the mother's side of the placenta, but no reports of it crossing to the baby's side at this point in time. And what we also know is that the virus has not been detected in the human breast milk of COVID-19 positive women at this point. But of course, infection control measures still need to be taken to protect the breastfeeding newborn. And more broadly, I guess we can probably conclude that distancing and hand washing precautions are particularly wise in pregnancy to minimise the chance of contracting the virus as far as possible. And that is not least because there is no indication yet about why the 1% of people who get COVID-19 become critically unwell with it. And that is the biggest risk to pregnant women. And I also just want to note that I don't have time to talk at length about it today, but outside of the physiological impact of the virus to women and babies, what has also emerged as an extremely serious effect of it is that pregnant women in whom we know the risk of domestic violence and family violence to be increased are even more vulnerable to it while they're in lockdown or social distancing with already abusive partners whose stress levels are likely to be increased for various reasons. And of course, getting your head around actually having a baby, adjusting to feeding, generally taking care of him or her, and how you might maintain your own well-being and sanity is a challenge to expectant mums at the best of times, let alone when your support system can't be around to help you prepare. And of course, that is compounded if you have an existing mental health condition. So it's not only risks to the physical well-being of pregnant women and fetuses that the virus poses, it is social and psychological ones as well. And of course, I also acknowledge that most pregnant women have a partner, and we know partners are also particularly vulnerable to anxiety and depression as they await their baby's arrival, and that they also will be impacted by the changes to care and support that the pandemic has engendered. And on that note, I might turn now to consider what we know about the way the pandemic has impacted the way care is delivered to and experienced by pregnant women and partners. So when it comes to pregnancy and birth care, here in Australia and in many countries around the world, it is recommended that women have around 9 or 10 checkups with a maternity caregiver during pregnancy. Those checkups involve conversations about how the woman's going and usually a physical examination to make sure the woman and the fetus are well and that the baby's growing as it should be. The appointments are an opportunity for the caregiver, the woman and the baby's other parent to be reassured that things are progressing as they should be, and for any issues to be sorted out, physical, social, financial, whatever. Antenatal care, of course, also includes going to antenatal classes to be with other parents-to-be and to learn together really about how to get through labour and birth, how to handle caring for a new baby, all of that sort of thing. What COVID-19 has meant, though, is that none of that can happen in person. And while women are either being asked to check up an appointment, scans, that sort of thing on their own, they're not able to connect with others. But that connection is definitely being fostered by the creative ways in which many maternity services, in fact probably all maternity services, are trying to put into place to ensure that pregnancy care and advice remains accessible and inclusive. One example is our West Australian Country Health Service, which, for example, has a vibrant and frequently updated Baby Bumps WA Facebook page, which is chock full of relevant advice, links to live online classes, links to other information. It's excellent and I commend it to you. And just a few days ago, 150 midwives from across the Asia Pacific region came together in a video conference to share their ideas about how best to provide remote antenatal care, education and support. And I see also from my research into what's available that you can even do your pregnancy yoga in a live streamed class, so interesting times. When it comes to labour and birth, the number of people who can be with a woman during and after giving birth in most maternity services has been significantly reduced. And so has the time that their visitors, including the baby's second parent, can be there. In addition, many maternity services are not allowing, understandably, second parents or other support people to attend the baby's birth or visit afterwards at all if they have COVID-19 symptoms or are confirmed to have the virus. What's been interesting to us as midwives, though, is that this has led to a noticeable increase in the number of women choosing to move into midwifery-led models of care. Probably because it means that the woman will have at least one familiar person, her midwife, if her chosen support person can't be with her when she's giving birth. The other thing it's led to is a higher number than normal of women choosing to give birth at home. And we think that's because there are no restrictions on their partner being there. So lastly from me today, I just want to touch on the all-important postnatal period. We do know from a number of research studies on the topic that what matters most to women in the first days and weeks after having a baby is a positive postnatal experience where they're able to adapt to their new identity as a new mum, develop a sense of confidence and competence as a mum, adjust to the changes that having a baby brings to their relationships, get to know their baby, navigate ordinary physical and emotional challenges, and really just adjust to the new normal of motherhood and parenting, in particular in their own cultural context. Ordinarily, like with antenatal care and education, most new mums and babies would have had the opportunity to join community groups and contact with other mothers and health professionals in that period to help them support that transition, find connection with others in the same boat, make friends, all of that kind of thing, obtain reassurance and guidance. But because the inability to gather in groups at the moment is not possible, it means that, as with antenatal education and care, wherever possible, services around the world seem to have moved very quickly to providing spaces for connection online for new mums and second parents in all sorts of offerings, as well as in the traditional mums groups. And one of the examples I want to give you is here at Edith Cowan University, for instance, our pregnancy to parent service, which supports expectant and new families that are very vulnerable to or have developed suboptimal mental health, has moved in a matter of a couple of weeks to the clinicians providing telehealth services from their own homes to approximately 50 families within the Perth metropolitan area. Many counselling services around the world have switched to video conferencing, and there are lots of other fine examples around the world of groups that women and their partners can join that each local maternity service and most general practitioners, as well as Google, of course, would be able to point people to. And now my time is almost up, so to summarise, pregnant women don't seem to be any more at risk of contracting COVID-19 than any other adult, nor is the illness more or less severe for them. The virus does, on the surface of it, seem to increase the chances of preterm labour, preterm rupture of membranes and preterm birth, but there is much we don't know about how ill those women were in those cases, and other information that's critical to take that as read. What we also know is that there doesn't seem to be any passing of the virus from mums to babies through the womb or through breast milk, but we also know that new information is coming to light every day, so we must bear that in mind. And although nowhere near as good as being with people in person really, there are lots of great options for women to connect with others and be supported through pregnancy, birth and the early postnatal days and weeks. So thank you very much again for listening. I can see there's a few questions and we do have a few minutes for them. This is from Michaela. Thank you, Michaela. Do we have any advice for mums due to give birth in a hospital within the next few weeks while the virus is still a risk? In broad terms, the hospitals are doing everything they possibly can to minimise the likelihood of anybody in that situation having the virus transmitted to them or of them transmitting the virus to anybody else. They are wearing full protective equipment, which is a mask, a shield, caps, gloves, gowns, all of that sort of thing. So essentially, a hospital is a very safe place for you to go to have your baby. As I said before, if your partner or your support person tests positive or has symptoms of the virus, they are unlikely to be able to accompany you. So the only thing perhaps you might consider is a backup support person. But otherwise, you'll have a great experience, and I wish you all the best. The second question is from Esther. Thank you for a reassuring presentation. Can a COVID-19 positive mum practice exclusive breastfeeding? She certainly can, and it's highly recommended, not least of all because of the immunoprotection that breastfeeding gives to newborns. So the advice for breastfeeding mums is if they are COVID-19 positive, that they wash their hands, they practice infection control measures. Some services are recommending that the woman wears a mask while they're breastfeeding just to prevent that droplet transmission, but there is absolutely no reason why that cannot continue now. I've got an anonymous question here. Thank you, Anonymous, for joining us. I have a concern around support partners not being present directly after birth. Are hospitals introducing this, and if so, are there more midwives and nurses rostered on? I can't speak to whether there are more healthcare professionals rostered on. That's something that individual services will need to do. What I do know is internationally, absolutely across the whole obstetric and maternity care support system, there is a massive concern among health professionals that families are being separated. In our state tertiary maternity hospital, partners are able to be with women for an hour after the birth, and it's just to keep everybody safe. And again, I guess that's why women are choosing to perhaps either discharge home early and have supporting maternity services visit them at home. But essentially at this point in time, there is a limitation. Hopefully we'll get back to normal soon. Carmen's asked us whether now we're able to gather in groups of 10, do I think face-to-face classes will resume shortly? I absolutely, hand on heart, hope so. And I think every antenatal educator will be looking very, very hard about how they can start to put their classes back on. I think as long as it's the same with every social event, isn't it? I think as long as physical distancing can occur in the space that that class is held, there should be no reason why groups couldn't gather now. And I guess individual educators will make that call. What else have we got? Carmen's asked if we know if King Edward are doing any online classes. I don't think they're doing online classes, but what I do know is that they have put up a number of resources which have links to online education. So it's certainly worth going to the King Edward Memorial page, King Edward Memorial Hospital page, looking at their COVID-19 information and just navigating through, because it will take you to the education portal where those links are. I've got a comment from Susan who asks, is there a general view on family interactions when the baby is born? Is social distancing advised with close family in the early days? It is encouraged. Essentially we are supposed to be not isolating, but we're supposed to be in our home with our very closest people that we live with, and particularly elderly people are advised to stay away from others. I guess again, I don't want to say this is my absolute advice, but if there is any potential for really good infection control to be carried out, then each family has to make its own decision in that regard. And certainly as health professionals, we do get it that grandparents are hanging out for cuddles from new babies, aren't they? And there's lots of really heartbreaking images online of them meeting their baby for the first time through windows. And I guess all I can say is we hope we're not going to be in this situation too long, but yeah. I've got one more there and we'll make this the last one, thank you. So how quickly can you discharge yourself from hospital after birth to be at home with your family? If you have a normal birth and everything's fine and the baby is well, generally most maternity services in the public sector at least will support you to go home between 4 and 6 hours after birth. You do, with that, get follow-up visits at home from a midwife, and yeah, it's as good as staying in hospital if you are well and healthy, because you can get into your routine, you can have your partner's support, and yeah, it's something that most maternity services do. So with that, I will say goodbye, and again, I appreciate you taking the time to join us today for this short webinar. If there are any other questions after you have a think about what we've spoken on today, you can certainly contact me. I've got email address and phone number through the Edith Cowan University website. If you just search through my name, you'll get to that information. And I wish you a very happy International Day of the Midwife. Bye-bye.